Introduction, I will tell you about the polyarteritis nodosa or PAN. So it is a systemic necrotizing vasculitis, but it's typically limited to cutaneous and we call it CPAN, cutaneous polyarteritis nodosa. And PAN is typically affects the medium-sized arterial vessels, but it also can affect the small arterial vessels. There is two types of PAN, primary and secondary, which is correlated with hepatitis B virus. It is a rare disease, but the clinical management of PAN is usually difficult, and the prognosis of PAN is often poor. So it is important to us to get a better understanding about PAN. So this is the learning scope of our presentation today.
Polyarteritis nodosa is a disease of systemic necrotizing vasculitis in blood vessels that lead to vessel wall necrosis. It usually targeting medium-sized arteries. The spectrum of the disease ranges from involving a single organ to polyvascular failure. However, it doesn't affect lungs. To classify this disease, American College of Rheumatology established classification contains 10 criteria. Patients with polyarteritis nodosa suspected by having at least 3 of 10 criteria.
Okay, next about etiology. The primary cause of PAN are idiopathic. The secondary PAN is less frequent and often seen in hepatitis B and C. The impairment in the endothelial function is believed to perpetuate the inflammatory reaction. The patient who develop hepatitis B may develop PAN usually within the first 6 months of the infection with the use of hepatitis B vaccine. The case of PAN have dropped. And next is genetic, the loss of function mutation in ACR1, also known as adenosine deaminase 2 or AD2, the gene that encodes AD2 has been related with the spectrum of vascular and inflammatory phenotype that includes polyarteritis nodosa. And the third is other disease that besides the hepatitis and genetic, there several other organisms have been linked to PAN, including Toxoplasma, Pseudomonas, trichinosis, and Parvovirus P19. In addition, PAN has been linked with the rheumatoid arthritis and hairy cell leukemia.
Polyarteritis nodosa, or PAN, is usually diagnosed in middle-aged and older adults. It affected men more than women. In 2004, an international PAN survey of 22 pediatric centers identified 110 children, of whom 63 children had systemic PAN and only 33 had cutaneous PAN.
Now, I'm going to explain the pathophysiology of polyarteritis nodosa. Polyarteritis nodosa mainly attacks bifurcations and branch points of small until medium-sized blood vessels. The inflammation begins in tunica intima and progresses to the entire arterial wall that results in fibrinoid necrosis of the vessels. Following the fibrinoid necrosis is the elevation of gamma interferon, interleukin 2 and interleukin 8, which play roles in chemoattractant and activating neutrophils. In this process, circulating soluble adhesion is also elevated and therefore originates the activation of endothelial cells. There are also presence of dendritic cells as well as the abundance of CD4 lymphocytes in blood vessels that are affected by polyarteritis nodosa.
A report said that 20% of patients with polyarteritis nodosa has hepatitis B. Polyarteritis nodosa can be triggered by hepatitis B by two mechanisms. First, virus replicate and induce the direct injury of the vessel wall. Second, the vascular lesion occurs as the result of deposition of circulating immune complex, the antigen and antibody binding. Then it attracts complement and activates neutrophil to come to the site of deposition that cause further inflammation and destruction. In later stages, the deposition of complex antigen antibody in blood vessels will lead to aneurysm that has a risk for rupture of blood vessels. Trauma may develop at the site of lesion and together with proliferation of intima or media may result in vascular obstruction that could lead to tissue ischemia or infarction.
Biopsy is very useful in the diagnosis of polyarteritis nodosa. The biopsy findings of polyarteritis nodosa show vascular inflammation and fibrinoid necrosis involving all vascular layers as well as disturbance of internal elastic lamina in small to medium-sized arteries as follows. From the figure 1 and figure 2, we could see the inflammation of blood vessel and the fibrinoid necrosis in medium-sized arteries. And from Figure 3 and Figure 4, we could see the vasculitis associated with fibrinoid necrosis of the mesenteric artery and the thickening of tunica media and tunica intima and narrowing of the ventral spinal arteries.
Okay, I will tell you about manifestation of polyarteritis nodosa. So polyarteritis nodosa is multisystem disease that may be present with fever, sweating, weight loss, and severe muscle and joint pain. This disease can affect almost any part of the human body, such as skin, kidney, nerves, heart, genital, gastrointestinal tract, and many more.
Hello, my name is Angga with last digit to the number 194. Clinical symptoms such as liver radicularis, vertigo, malaise, also hypertension may occur in polyarteritis nodosa, according to ACR classification in 1990. In severe PAN will be found oliguria, increased creatinine level, and vasculitis. Biopsy showing necrotizing arteries and infiltration of granulocyte in vascular, while arteriography can show aneurysms in which arteries, and angiography will show microaneurysm changes in arteries.
So now I will explain about the treatment of polyarteritis nodosa. Polyarteritis nodosa have a mild and severe disease, and the treatment is based on the severity of the disease. For the mild disease, we can use glucocorticoid such as prednisone 1 mg per kilogram per day with a maximum of 60 to 80 mg a day. And this dosage is given over a month and slowly reduced over 6 to 8 months. But in some cases, patients with mild disease sometimes resistant with the glucocorticoids, so we can exchange the treatment into azithromycin or methotrexate. And for the severe disease, the treatment can be chosen are intravenous prednisone 1 gram per day plus immunosuppressive drug like cyclophosphamide. Next, if there are patients who suffer from polyarteritis nodosa and hepatitis B or C, they will get additional medication with antiviral lamivudine 100 mg a day. For patients with severe hepatitis B plus polyarteritis nodosa, we can add plasma exchange in addition to the antiviral therapy. When patients come with hypertension too, we have to give the ACE inhibitor drugs, and we have to always monitor the renal function. If there are indication of renal failure, give the calcium channel blockers to maintain the hypertension. And for the last treatment of polyarteritis nodosa is surgery. Surgery is required to manage bowel perforation, cholecystitis, and aneurysm of blood vessels.
The differential diagnosis of polyarteritis nodosa, there are granulomatosis with polyangiitis and microscopic polyangiitis. From autoimmune and or autoinflammatory disease, there are juvenile idiopathic arthritis, juvenile dermatomyositis, systemic lupus erythematosus, and sarcoidosis. And from malignancy, lymphoma, leukemia, and other malignancy can mimic polyarteritis nodosa.
A good prognosis of polyarteritis nodosa or PAN is obtained in patients if this disease has only skin involvement. However, the PAN prognosis can be indirectly deserved. In the data, it was found that 10 until 20% patients with PAN died without treatment, and patients on corticosteroid treatment have 50 until 60% chance of survival. PAN disease will involve damage to the cerebral and cardiac regulation system until joints, although it's just a disease that attacks the blood vessel. Because there are 32 from 36 PAN patient clinical sample who experienced the similar event, then this prognosis and complication can be important consideration for early management and treatment.
Polyarteritis nodosa is a disease of systemic necrotizing vasculitis which result in vessel wall necrosis. Polyarteritis nodosa attacks small to medium-sized blood vessel and sparse large vessels like aorta and capillaries, small arterioles, and venous system. Late-stage polyarteritis nodosa result in aneurysm, which could cause rupture and hemorrhage. It could be detected through biopsy, and the biopsy will show vascular inflammation and fibrinoid necrosis. The treatment for polyarteritis nodosa is based on the severity of the disease.